This is a case study presentation looking at a patient who has suffered a traumatic brain injury from a motor vehicle accident. This presentation is presented by Megan Chow, Adele Kurt, and Frances Callihan. To begin, we will discuss and provide basic information over traumatic brain injury and then explore the case of Judy Johnson.
According to Pedretti, a traumatic brain injury is defined as damage to brain tissue caused by an external mechanical force with resultant loss of consciousness and post-traumatic amnesia. Our client has sustained a closed brain injury, which is one that damages the brain tissues but does not penetrate the head and can occur when the brain undergoes rapid acceleration and deceleration. This is the anatomy of the brain. Depending on where the closed injury takes place and what aspects of the brain was injured, visual perception, speech, sensation, cognition, and motor may be affected. According to Trombley, each year approximately 1.7 million civilians in the United States sustain a TBI. Some of the common causes are due to falling, motor vehicle accidents, striking an object, and assaults. Some of the major symptoms that people often have are headaches, memory problems, movement problems, processing difficulties, and depression.
This is our patient, Judy Johnson. Judy is a 54-year-old female who has recently endured a TBI secondary to a car accident. Judy is happily married and has 2 children with whom she enjoys spending time with. Previous to her traumatic brain injury, Judy volunteered at the local hospital, enjoyed shopping, playing cribbage, and challenging her mind to a game of Sudoku. Judy engages in smoking and has previously experienced chronic back pain and anxiety. Currently, Judy presents with decreased functioning in her right upper extremity and lower extremity, increased tone in her right upper extremity, shoulder and wrist pain with passive range of motion, decreased strength in the right lower extremity, decline in cognition and safety awareness, right neglect, and agitation. Following Judy's TBI, her current goals are to be able to transfer and perform a self-care routine and functional transfers as independently as possible, as well as become more cognizant of general safety precautions and management. Due to the nature of Judy's past medical history and the effects of her TBI, she is taking quite a few different medications to alleviate various issues she is experiencing. Even though medication will help lessen some of the effects, there is currently no approved acute treatment for TBI patients. Judy is taking a multivitamin for added minerals, vitamins, and nutrients, Ritalin to help with her concentration, memory, and effective cognitive functioning, Prevacid to aid with jerky muscle movements and muscle weakness, Singulair for anxiety and muscle weakness and pain, and lastly Coumadin to decrease the pain in her wrist and shoulder of the right upper extremity. The Rancho Los Amigos scale is a tool therapists use to assess one's level of cognitive functioning after sustaining a TBI. Rancho levels are scored on a scale from 1 to 10, with a score of 1 showing no response and 10 showing purposeful and appropriate functioning. Judy has presented with obtaining a 5 to 6 Rancho level in which she is confused and showing between appropriate and inappropriate responses to goal-oriented commands and cues. This would lead us to believe that she will present the need for verbal cueing to complete tasks and activities during therapy sessions.
The Glasgow Coma Scale is a tool used to measure levels of consciousness after a TBI. The scale ranges from mild to moderate to severe. The classification of Judy's injury is mild. She is able to open her eyes in response to all sensory inputs and follow simple commands. However, she is often confused. Judy was referred to the inpatient rehab on March 16, 2014 after her motor vehicle accident and was diagnosed with Rancho level 5 and 6. Upon admission on March 17, 2014, the occupational therapist performed the following assessments: the Functional Independence Measure Assessment, the Canadian Occupational Performance Measure, the Visual Analog Scale, manual muscle testing and range of motion assessments, the Ashworth scale, and the cognitive assessment of Minnesota. We will be reviewing these assessments in further detail in a moment. To start, the Ashworth scale was used to obtain a baseline of Judy's upper extremity muscle tone. During the assessment, Judy presented with high muscle tone and static resistance throughout the duration of the assessment, giving her a score between 3 and 4. As you can see on the scores presented, Judy's admission FIM scores are currently at a moderate assist for almost all self-care, transfers, and cognitive activities.
The visual analog scale is a psychometric response scale to pain. It is a great tool to measure subjective characteristics of patients' pain levels. As you can see, Judy has a visual pain level of 8, and this is due to the passive range of motion in her right shoulder and wrist. Manual muscle testing is the evaluation of function and strength of muscles and/or muscle groups. Range of motion is the distance and direction a joint can move between positions. As you can see, Judy has some functional limitations with shoulder, elbow, and wrist strength and joint range of motion.
Another assessment used with Judy was the Cognitive Assessment of Minnesota, or CAM. The CAM is a screening tool that assesses a wide variety of cognitive skills, such as problem solving, awareness, judgment, and abstract thinking. As you can see, Judy obtained a mostly moderate score, meaning she presents with moderate cognitive impairments. Based on Judy's screening and evaluation, several occupational performance problems were discovered. ADL deficits, including decreased abilities in bathing, dressing, functional mobility, and grooming, were noted. Prominent IADL problems, including community mobility, health management and maintenance, and safety maintenance, were identified. Other areas of occupation where performance problems were indicated included social participation, leisure, work, play, and education. Through the evaluation, we also identified several performance skills that aided Judy's performance problems. Motor and praxis skills, such as motor sequencing, following verbal cues, overall body coordination, posture, and object manipulation deficits were prominent contributors. Judy also exhibited emotional regulation deficits as well as executive cognitive deficits such as planning and sequencing. Some of Judy's noticeable habits that may impede her therapy include smoking and spontaneously acting without thought. Several functional body problems were observed in Judy's assessment. Mental functional impairments, including attention, memory, perception, emotional regulation, and sequencing problems. Sensory deficits included visual perceptual problems, such as visual cognition and visual memory. As we have previously mentioned, Judy also presented with sharp, localized pain in her bilateral upper extremities and neuromusculoskeletal and movement-related impairments, such as increased muscle tone and decreased motor reflexes, joint mobility and stability, muscle endurance, and voluntary motor control. Therapy services for Judy included occupational therapists co-treating with physical therapists for the purpose of restoring functional mobility, strength, and ambulation of the lower extremities. When working on self-care activities, therapy will occur in the patient's room or bathroom. However, strength and endurance therapy should occur in the gym. Judy should be seen for therapy 1 hour per day, 5 days a week, for a duration of 3 weeks, and may be seen in the morning or afternoon depending on the patient and the goals for that session. Our goal for Judy is that she be discharged to an adult daycare program to continue working on therapy.
The long-term goals that Judy and the therapist collaborated on are as follows. First, Judy will demonstrate independent morning and night self-care routine by discharge. Self-care routines include personal hygiene, grooming, and upper and lower body dressing. Secondly, Judy will successfully perform tub and shower transfers with modified independence using adaptive equipment by discharge. And finally, Judy and her primary caregivers will successfully demonstrate verbalization and understanding for general safety awareness and health maintenance, psychosocial factors, and available community resources by discharge.
Frames of references are approaches for evaluations and interventions used by occupational therapists. They are specific and based on scientific and therapeutic concepts. Frames of references outline functions, strategies, procedures, protocols for interventions, assessments, and desired outcomes to be achieved. They help a patient to adapt, prevent, promote, restore, and maintain occupational performance. There are 5 frames of references, as you can see, that are being utilized with Judy in her TBI diagnosis. Based on the goals the OT and Judy collaborated on, the biomechanical, rehabilitative, multi-context treatment approach, task-oriented approach, and psychoeducational frames of references are incorporated throughout each goal. As you can see, the biomechanical and rehabilitative frame of reference each target motor performance. The multi-context treatment approach addresses the cognitive aspects. The task-oriented approach looks at motor performance while considering the client factors, context, and environment of the patient. And lastly, psychoeducational is for developing strategies to modify and cope with the effects of TBIs.
The first long-term goal established by Judy and her therapist was that Judy will demonstrate independent morning and nighttime self-care routines by discharge. To accomplish this goal, 3 short-term goals to help improve her independence in ADLs were created. The short-term goals listed under this long-term goal rely heavily on Judy's gradual increase of independence while performing her ADL activities. Therefore, for the first week of treatment, the focus was on establishing a foundation for further improving skills and abilities in order to increase activity safety and endurance. This was done through preparatory activities, including energy conservation techniques, stretching, and light upper extremity exercises. During the second week of treatment, the focus was on adapting Judy's ADL activities using adaptive equipment, which supports her occupational independence and self-reliance. This was accomplished through purposeful activities, including adaptive equipment education and training, and through practicing ADL preparation. On the third and final week of Judy's therapy, treatment was focused on creating and promoting her ADL routines. Creating a self-care routine is beneficial in that it promotes Judy's participation in her own personal hygiene care. Occupation-based activities, such as performing her morning dressing from beginning to end, using adaptive equipment for support, and thoroughly practicing her hygiene routines, were used to promote Judy's self-motivation and personal care. There are many activity demands for Judy based on her therapy goals. Overall, it is important that she perform her ADLs in a well-lit room or bathroom, and that she have sufficient joint mobility, finger dexterity, and functional cognition to complete the desired tasks. Sequencing and timing are also important activity demands to address with Judy. Due to her cognitive deficit, it is important for her to properly sequence her activities to correctly complete the overall task. Judy's personal context and environment should be considered as well. Awareness of her temporal and physical environment will help Judy know which activities to perform as well as be efficient in her routine performance.
The second long-term goal that the OT and Judy collaborated on is successfully performing the tub shower transfer with modified independence using adaptive equipment by discharge. In order to achieve the final goal, there were 3 short-term goals put into place to build up strength, stamina, and cognition to be successful in achieving this long-term goal. Due to the fact that Judy will have therapy for 3 weeks, short-term goals have been broken down by week, increasing the amount of independence required of Judy. The first week will take an established restorative approach with preparatory activities. In order to increase Judy's muscular strength, endurance, and range of motion to maximize her tub-to-shower transfer with moderate assistance and less than 10 verbal cues, we will have a co-treatment with PT and bilateral lower and upper extremity strengthening and endurance exercises. Along with these activities, Judy will obtain instruction on the bilateral lower and upper extremity positioning and sequencing required to perform this activity successfully. During the second week, we will take an adaptive and modifying approach using purposeful activities. Instruction and education of the proper adaptive equipment usage will promote safety awareness, executive cognitive functioning, and strategies to improve Judy's overall well-being and quality of life. She will be able to demonstrate tub shower transfers using a walker and shower chair appropriately with moderate to minimal assistance and less than 5 verbal cues. Co-treatment with PT will also be given during this week for ambulation, functional mobility, and bilateral lower and upper extremity strengthening and endurance exercises. Judy will be asked to recall the education that was given on the adaptive equipment that she will be utilizing during this activity. She will also demonstrate a tub and shower transfer using the adaptive equipment and with moderate to minimal assistance from the OT. The third and final week will also take an adaptive and modifying approach, but it will use occupation-based activities. Recalling the usage of the adaptive equipment will help Judy to promote and increase the executive cognitive functioning and self-confidence that she will display while she is transferring with the adaptive equipment in less than 2 verbal cues. We will ask Judy to recall the education on this adaptive equipment, as well as demonstrate the tub and shower transfer. There will be a co-treatment with the PT for the bilateral upper and lower extremity strengthening and endurance exercises. There are many different aspects of the activity for this long-term goal that will influence Judy's ability to complete and be successful in accomplishing her goal of functional transferring to the tub or shower. The activity demands, as you can see below, are the objects and their properties, space demands, social demands, sequencing and timing, and required actions and performance skills. The objects that are being used for this goal is a walker that has 4 legs, 2 with rubber stoppers and 2 with wheels, a white tub shower bench, and light weights that she will utilize during her bilateral upper and lower extremity strengthening and endurance exercises. Judy will perform her transferring in the bathroom, in the hospital, and it will be open, well-lit, noise, and clutter-free. She will perform her bilateral upper and lower extremity strengthening exercises in the OT gym. The social demands that Judy will be facing during this activity and goal is interaction between her caregivers, the occupational therapist, and the physical therapist. The sequencing and timing of this activity will depend on the steps needed to carry out the functional transfer, as well as the amount of time it will take for Judy to complete it. In order to complete and be successful at this goal, Judy will need to be able to ambulate and be able to transfer successfully and independently with her modified adaptive equipment. The skills that are needed for Judy to transfer are motor and praxis, sensory perceptual, emotional regulation, and cognitive skills. Some of the actions that are required from Judy are gripping the walker and handlebar in the bathroom and determining how to move her limbs in conjunction with performing the transfer. Along with the different demands the activity poses, there are also many different aspects of Judy's context and environment that influence her ability to complete and be successful in accomplishing her goal of functional transferring to the tub or shower. For her personal context, Judy is 54 years old. She is a wife, a mother, and a volunteer. The temporal aspect of her context is the time and location of each OT session, whether it will take place in her hospital bathroom or in the OT gym for her exercises. The physical contextual component of this activity is the hospital room in which Judy is residing in. It is well lit with 2 windows, a hospital bed, a chair for her husband and visitors to sit in, and the walker that she uses to ambulate. The social contextual opponent are the caregivers that are present, her family members, her friends, and the therapists that help her with her day-to-day activities.
For her final long-term goal, Judy and her primary caregivers will successfully demonstrate verbalization and understanding for general safety awareness and health maintenance, psychosocial factors, and available community resources by discharge. Judy and the therapist have created 3 short-term goals to be implemented throughout the 3 weeks, and we will be discussing these 3 short-term goals in further detail in a moment. For the first short-term goal, Judy and her caregivers will verbalize understanding of instruction and education of psychosocial factors. We will be using purposeful activities in order to understand and identify negative emotional triggers, and we will practice different emotional regulation strategies in order to help establish psychosocial management skills. For the second short-term goal, Judy and her caregivers will demonstrate understanding of instruction and education of safety precautions by verbalizing safety precautions at least 2 times during each session by the end of the second week. We will be using purposeful activities and will practice instructing, educating, and giving repetitive verbal or visual feedback and reminders during each session in order to help prevent future safety concerns. And finally, by the end of the 3rd week, Judy and her caregivers will be able to verbalize and show understanding of where to find available community resources and the importance of overall health management and maintenance pertaining to her TBI and/or cognitive status. We will be using occupation-based activities with Judy and help her create a daily routine and participate in a community support group, which will help promote her overall health management and independent functioning and well-being. In order to increase Judy's understanding of education and the general safety of ADL and IADL activities, she must be in a quiet, well-lit environment so that she does not become easily distracted. In order for her to engage in and participate in her own learning, it is important that Judy be able to answer questions, problem solve, and repeat and verbalize learned concepts in an appropriate language. We will be utilizing a variety of community resource tools and materials and safety awareness visuals and documents. The context and environment that Judy requires to facilitate achieving her final long-term goal is an open room that is free of clutter and distractions with good lighting. We may utilize online community resources and may use a variety of tools, such as a smartphone or tablet, in order to organize a routine and improve her memory for daily activities. Her primary caregivers, friends, and support group peers may also be present to help Judy achieve this goal successfully. Overall, each long-term goal could be graded to be easier or harder depending on Judy's progress. For example, 3 ways we can make the activities easier would be to provide her with more verbal or visual cues and instructions, or we could provide her with more rest breaks, or provide her with more assistance. And 3 ways we can make the activities harder would be to decrease the amount of verbal or visual cues and instructions, increase the activity endurance needed for each session, and decrease the amount of assistance.
The discharge plan that we have set in place for Judy is that she will be discharged in 3 weeks from an acute rehabilitation setting to go to an adult daycare program. She will continue to see the community-based occupational and physical therapist for 4 months, as well as having biannual checkups with her physician. Upon discharge from acute rehab, the occupational therapist recommends and has educated Judy and her family to continue a home exercise and strengthening program, as well as continuing to use her adaptive equipment.
As you can see by the change in Judy's initial admission FIM scores, she has shown tremendous improvements at discharge. She is now at a modified independence in all self-care routines, functional transfers, and social activities.
Judy was discharged on April 7, 2014. She has independently performed self-care activities and has successfully performed tub and shower transfers with modified independence. Her family and caregivers have been educated on safety management, cognitive activities, and home exercises and endurance programs. Since discharge, Judy has been participating in an adult daycare program and has been receiving therapy. The anticipated outcomes we see for Judy, 1 year post-discharge, are that she will show increased strength and endurance, in her right upper extremity with increased manual muscle testing and range of motion scores. Judy will also successfully perform self-care and transfer activities as independently as possible. Overall, Judy is progressing well and increasing her independence. We look forward to monitoring her continued progress. Thank you for watching our presentation. We hope you enjoyed it. If you would like more information on traumatic brain injury or anything else discussed in this presentation, please feel free to explore the references below.